Good afternoon, and welcome to Achieving Standardized Clinical Communications for Improved Patient Care, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate on your phone or in a separate browser using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, and you can use that to send in your questions at any time. We'll take them later in the program, and you can leave the default set to all panelists. And you can download the deck by using the URL on your screen below. Just so you see how we're going to spend our time, first we're going to have our featured presentation featuring Nick Wirth, Director of Operational Excellence with the Hospital for Special Surgery. And then we'll hear from Peter Grimaldi, Assistant VP at the Hospital for Special Surgery. So without further delay, I want to turn it over to Nick Wirth. Nick, thanks for joining us today.
Thank you, Anthony. Today what we're looking to walk you through is tell you a little bit more about Hospital for Special Surgery, and so you can get a sense of who we are, talk through the driving forces for change, why we went through an implementation of a clinical communications platform, walk you through our approach and the deployment strategy that we used, go over some of the results, and then some of our successes and lessons learned. So HSS is located on the Upper East Side of Manhattan. It's an academic medical center that's been top ranked for orthopedics and rheumatology for quite a few years. We have about 350 medical doctors on staff, or physicians on staff. Of those, about 110 of them are orthopedic surgeons. And we really treat patients from all over the country and from over 100 different countries. What makes us a little unique compared to a multi-specialty hospital is the fact that we don't have an emergency room, but there's still the same need for throughput. Really, we're doing about 32,000 orthopedic surgeries a year, so as you can imagine, similar to an ER needing to quickly reach the providers throughout the organization, we have a similar need in reaching out to the perioperative medical doctor, the physician assistants, and multiple other specialties in order to keep that throughput, in order to achieve that volume every year. So what you'll hear us talk about is there's a similar need, and just because we don't have an emergency room, there's the same kind of need for a clinical communications platform in the organization. And so with that, I'm gonna transfer it over to Peter, and so he can talk about some of why we went through this implementation.
Thank you, Nick, and thank you so much for allowing me to partner with you on this initiative, and thank you, Anthony, for the introduction earlier. To kind of level set our talk, it's important to kind of understand the journey we've been on, and this journey we started back in 2016. In 2016, we decided to overhaul our entire electronic health record. So that was a huge initiative. We involved all the frontline staff to kind of be involved with the design process. At the same time, we kind of initiated a lot of transformational assessment, kind of look at our processes, what can we do differently, what can we do better to deliver a better product to our patients. What we learned real quickly was that the sophisticated EHR and everything we wanted to realize in our transformation efforts were not very conducive to an analog paging system. We were still on analog pagers, and that was a real void, a real problem in our ability to realize everything we wanted to. So that really created the burning platform for us to overhaul our and transform our communication process, and kind of arrive at a standardized communication platform that with the goal of getting integrated care. If you could please advance the slide, Nick. To fully appreciate where we've come. We need to have a sense of history and know where we were. And in our former state, excuse me, with the analog pagers, you know, what were we suffering from? Well, whenever we received a page, we didn't have any context. We didn't know what was on the other end of that page. Was it something routine like a renewal of a throat lozenge, or was it a decompensating patient that you know, needed some urgent attention? So we didn't have any context. Additionally, when you're receiving multiple pages as you manage your patients, you had no ability to triage. Well, what should I do first? You know, how do I prioritize my day? You can't do that in an analog paging system. Additionally, with the paging system, there was no ability to escalate. If we had certain problems that arose, our frontline staff are charged with escalating to the appropriate providers, and in an analog paging world, you didn't have that ability. Communication, very, very important, and because of the fallacies, the weaknesses with a paging system, what we ended up having is behavioral and cultural evolution in terms of how we communicate. Suddenly, we were using our cell phones, we were using email modalities, you know, all the other modalities that, other than something that should be kind of standardized and integrated into our EHR, were being utilized, and it resulted in a lot of inconsistency in how we deliver the various messages. Lastly, you know, if there were gaps in a coverage model, let's say, if somebody were, you know, inadvertently didn't assign themselves to a role, you couldn't easily identify those gaps. You know, in that world, there was no real way to kind of easily identify it until the gap was obviously exposed because somebody wasn't managing a given issue. We had a lot of questionable reliability with the paging system. There were a lot of dead spots throughout the organization. And we were also, in the outpatient world, we were contending with multiple answering services. So we wanted to have a system that could have measurable and improved responsiveness as it related to communication and patient care. Nick, if you could advance. So, you know, as we kind of fleshed out our strategy for a united clinical communication platform, we had to get a sense of what was the current environment. And what we realized is that we had a very complex staffing model, right? We deliver 24/7 inpatient coverage and that manages our patients preoperatively, intraoperatively, postoperatively, and we also have outpatient call and off-hour escalation policies in terms of issues that might occur off hours. At our organization, we have 50 orthopedic fellows. We have the largest orthopedic residency in the country. We have 70 private physician assistants and about 103 department physician assistants. So what invariably is happening is you have kind of a fractured care model where these individuals might be have similar responsibilities, but they're not necessarily coordinated under one table of organization, one leadership structure, and that can create gaps in care. We also needed to keep up with the evolving care model and the changing priorities for academic staff. You know, 15 years ago, our residents and fellows were very much more involved with the patient care at the bedside, but their priorities have shifted more away from the bedside, more involved in the OR, more involved in our offices, and of course, research. So that really was one of the things that initiated the onset of having advanced medical providers like PAs, like NPs in your system. Some of the gaps in that we wanted to address, we wanted to have one-stop shopping, right? We wanted to have one system to address all our communication needs. We needed a two-way communication system, and we wanted a way to measure success, you know, how are we doing as it relates to communication, and also be able to diagnose, do we have a system issue versus an individual or a user issue? That wasn't always clear. Nick, if you could advance. So, you know, in our current environment, what we're dealing with here is our institution. We have a lot of volume. We have high volume. We have a length of stay that's consistently decreasing through the years as the orthopedic care model evolves, and that really makes kind of our care coordination extremely complex and extremely fast-paced. A lot of volume of conversation within the organization, and we truly do adopt a culture of communication here at HSS. We have things like handoff policies, transitions of care policies, all with the goal of really improving the communication from clinician to clinician. We also expected, more timeliness of our communication so we can make quicker decisions and manage our patients more efficiently. In terms of care coordination, unlike a lot of the care team clinicians, like a nurse or a social worker or a therapist, who are often kind of located on a given unit, our providers, our PAs, MDs, et cetera, they're not necessarily local. They're often throughout the organization, multiple responsibilities, so they're not always physically present on a given unit to manage a given issue face-to-face. So clearly we needed a more sophisticated way to communicate to address that need. The other thing that we were also dealing is that we saw a value in adding additional layers of care. An example of that is in the past couple of years, we added the role of the clinical pharmacist to help with our medication management, and that is a very important role, and again, yet another layer of care that in a fractured, flawed communication system, we were destined to fail. When it comes to managing patients at the provider level, we have benchmark patient-to-provider ratios in terms of our staffing. We needed the ability to adjust quickly to changing situations. If you have a decompensating patient, you have to escort the patient, on a monitor off-site or for a particular study. You had to be able to manage all that. You also have situations where certain services workload is unbalanced. Perhaps a given service is is busier than the other service, so you might have some staffing issues that either slacken the system or constraint in the system because of those imbalanced service workloads. If you can advance to the next slide, please. So clearly there was a financial incentive too. We wanted to phase out our dated technology in terms of the analog pagers. We wanted something that was more reliable and fully integrated into our EHR because of the climate where our length of stay is dropping, our throughput's increasing, and and everybody in our healthcare systems is dealing with reducing readmissions. So that was our goals, and I want to transition back to Nick at this point.
So at the end of 2015, our surgeons were really coming to talk about their failing answering services, and I led at that time a group of surgeon office transformation initiatives. In that group, this was prioritized as one of their top 4 issues that they were dealing with. At that same time, in February of 2016, we went through an entire EHR implementation throughout the hospital and our outpatient areas, and that was a phased approach throughout 2016. So we knew we couldn't implement both a clinical communications platform and an EHR at the same time. As Peter mentioned some of those gaps, during the same time period, our inpatient teams were talking about the old analog pagers that they would get bombarded, and it almost felt like a switchboard operator where the person holding that pager would receive all the communications, and it would be their job to triage and forward to the appropriate team with those different layers that Peter mentioned. At the same time that they were getting bombarded, it was also around the context of those messages to determine if I were to get 3 messages at the same time, which one is the highest priority and should I be able to follow up. So we knew about the gaps, we knew about the challenges, and it was really about our approach and how we were going to address them at the same time of going through the EHR implementation. So the approach that we took, we knew we wanted an organization-wide vision, bringing everyone onto one platform. So, for instance, at that time, we had about 6 different answering services that our physician offices were using. And as you can imagine, emergencies come up, things need to change. If there was ever a switch between 2 attendings or fellows who was taking call for that physician's office, as you can imagine, on the weekends when there was 1 attending covering all the offices on a service, they would have to update potentially all 6 of those answering services plus the hospital, and which creates a lot of room for error, and especially on the weekends when there's a lot less staff here, administrative staff, being able to update all of those different companies and systems it leaves a lot of room for error. So what we said was our approach, we're going to have one platform that everyone's going to be using that can provide real-time updates when a change occurs. We also, since the EHR implementation was going on, we wanted to start in our physician offices in adopting the new technology so that if it went well there, we could do a small contained pilot and really make all the tweaks we needed so that we could roll it out in all the rest of our physician offices, and then if it worked well there, bring it into the hospital after the EHR implementation was over. So we established a small governance committee that I mentioned, which was our surgeon office transformation to work on physician office initiatives. And then as the project grew and it was successful in the physician offices, we worked on establishing a much larger governance structure with the different hospital clinical departments. I think we had about 20 different team members on that steering committee from all different subspecialties. That steering committee, once we got through the EHR implementation, was really tasked with, by our leadership team with addressing those top challenges and those gaps that Peter mentioned and figuring out a solution to meet those needs. So after that group kind of came up with their top recommendations that I'll go into in the next slide, we then said we wanted to standardize workflows across departments, so where we could. So we wanted to determine what things should be standard for the organization versus what should we leave up to the individual departments to decide on. So things like escalation protocols, responsiveness times, we tried to standardize certain measures that we wanted to meet. And really what phase of this approach we're in now is really that optimization phase and further integrating with our EHR that I'll discuss in a few slides. So coming out of that larger steering committee, the recommendations were to bring both the inpatient system and the outpatient system into one platform. Bringing all of those call schedules, coverage assignments into the same technology that would allow for those real-time updates that were needed. So if emergency came up or a surgeon was going to be in the OR longer than they needed to, someone called in sick, someone could make a quick change and they could make it from anywhere and it would update the entire organization. We also wanted to connect our clinicians and our providers with bidirectional texting. So historically, a lot of times what you would hear are the nurses sending a page or a message to a provider, and a lot of times all it would require is an acknowledgement or, you know, an okay, I just put the order in. And historically, it would be a phone call back to that nurse, and you would have to sometimes get the unit who would have to find the provider, and it would be this long communication cycle that was really unnecessary. So what we wanted to do was be able to provide that bidirectional texting between the two people to close that communication loop much more efficiently. We also wanted to enable patient assignments by individual provider. So as Peter was mentioning, and we talked about earlier in kind of why we went through this change, whoever was holding that pager when we had a paging system, they would be the ones that would get bombarded. And so we wanted a way where we could assign someone to a service or to a department, but there may be 3 different providers on that service, and we wanted the ability to say, to break out the workload between all 3 people on that team, rather than that one sole person getting all of the message, having to triage and forward to the appropriate person. So I think that was a very good recommendation that we came up with, that we saw a lot of benefits downstream that we'll talk about. We also came up with acceptable response times. So Peter's team, our physician assistant department, you'll see in some of the results, we said that it's the expectation that messages are read or acknowledged in under 15 minutes. We have certain other clinical message types that require a higher escalation that we built in these protocols in order to achieve and then be able to measure against what we've recommended to make sure that we're hitting those measures. And finally, what we needed to do was develop a clinical communication policy for the organization and bring it to our medical board for approval to make sure that this was being followed and adopted by the entire medical staff and anyone that would be communicating about patient care. So the way we went about rolling this out throughout the entire organization, I talked about we started in our physician office, but then when we moved over to the hospital, we started really with this core, this purple area here, and we said anyone who is a prescriber on our nursing team and our rehab therapist, they need to be phase 1 and kind of mandated, they need to be on this platform. We then said anyone in this, what we call the indirect patient care responsibility, so who do those prescribers, nurses, rehab therapists need to communicate with the most? So obviously the lab and the pathologist. We have a lot of international patients and patients who don't speak English as their first language, so we wanted to put on our language services team so that we can our providers can quickly get an interpreter to the bedside or an exam room to provide that level of service. Our case management team, our food nutrition team, and our pharmacy, people that they need to interact with most commonly to provide that, that additional layer of patient care. And then finally, after we got through those 2 phases, we started looking at what other departments in the organization had call and coverage schedules that should be incorporated into this based on our steering committee's recommendation that all call schedules will be housed in the same technology. So we started looking at departments like engineering, environmental services, our administrator on call, departments where if there's an issue, so say we need to turn over an inpatient room quickly, we needed our EVS team to be able to quickly get to that room and turn it over. If there was ever, at one point I think we had a water leak, we were able to go through our clinical communication platform, quickly get to engineering to address the issue. So as I was talking about those 3 circles for our deployment strategy, this is kind of how we broke them out and when they would go live. So as you can see, it was you know, a multi-phase, but also over the course of about a year and a half to do so. So we started with that pilot with our foot and ankle surgeons at the beginning of 2016. We actually went live with that group in the answering service component the same day we went live with our EHR implementation at the hospital. After we proved success with them, we rolled out to the rest of the physician practices as in parallel to our EHR implementation. Once we got through all of the EHR implementation, we then quickly brought it over to pilot with our hospitalists and internists in taking care of our inpatients. And at that time, we saw success in the platform, but we didn't have that bidirectional texting component. So we worked on the full hospital implementation quickly after that, and we went live in April of 2017 with that core group that I mentioned. So we made sure our prescribers, our nursing team, and our physical therapists were on the platform from the beginning, while we then rolled out to the rest of Circle Tier 2 and Tier 3. And as we've gone into 2018, we've started to do some optimization and integration that I'll go into, and I think we've seen a lot of efficiencies come from that. So we're really starting to look at what message types do we not need someone manually to send? What things are triggered? Messages are triggered from some cue in the EHR that someone's manually looking at and then reaching out to a provider. What can we do to automate that process? So going into some of our results, so our adoption rates, we have about 3,400 people in total at our organization using the platform. 700, a little over 700 of those are prescribers, over 165 of our practices, and 1,300 people were having used mobile devices, and we actually instituted a bring your own device policy at HSS. some of our response times that we've seen, and actually updated this at the end of April, we've seen from our PA department, they are our highest receivers of messages in our organization. And since go live in our first year, we saw 97% of all conversations that are initiated to them are acknowledged in under 15 minutes, which is, you know, an amazing, we can't really measure what it used to be in a pager world because there is no ability to report on the acknowledgement time. But as Peter will probably also mention, I mean, it was a huge improvement even though we didn't know the response times to measure off of. And overall, just for our PA department, their average response time is actually much better than the 15-minute mark. They're actually averaging 3.3 minutes from the time a nurse is initiating that conversation till when they get in an acknowledgement. Some of those escalated message types that I was mentioning before that we put in higher protocols for. So we have a sepsis response team and a sepsis alert process that we've instituted. We have a modified early warning system we call MUSE, which is the nurse initiating it to a physician assistant. 96.3% of the time that's actually acknowledged in under 5 minutes because of our policy that we want to hit that 5-minute mark for these. And we also instituted our rapid response team process into the clinical communication platform. And since we went live with that, we've seen the entire team acknowledge the message in about 1.9 minutes. We also started to look at patient satisfaction results. So we obviously, as we instituted new technology and we started having people be on their cell phones, we wanted to make sure patient satisfaction was actually increasing or being stable in this implementation. And what we saw is our overall hospital rating increased by 2.3 points. And then we looked at some of the questions that feed into that. And so we looked at things that could have been related to communication. So the likeliness to recommend the hospital, the staff ability to address emotional needs, and the response times all also went up after the implementation of the new technology. With this, I'll turn it over to Peter to talk about some of the clinical results that we saw.
Thanks. Thanks, Nick. So some of the additional successes around communication throughput, starting with the first graph, you can see we saw an improvement of 13 minutes over the course of 2017 in terms of our ability to discharge our patient from our PACU or recovery room. And this speaks to a couple of things. It speaks to, one, the importance of maintaining throughput and ensuring a patient is ready for a PACU discharge, ensure that that discharge is a safe discharge. It's important from a efficiency perspective because, slowness in our PACU, that's a big obstacle to throughput and certainly could lead to our operating rooms going on hold and further upstream delays that it could also inevitably result in cases being canceled, worst case scenario. This measure also speaks to the timeliness of our patient exams. Of course, all our patients get post-op checked in the recovery room prior to going up onto an inpatient unit, and we wanted to see the patients in a more timely manner and be able to measure that. Spoke to some of our study results being performed and resulted in a quicker manner. Certain patients require certain studies, perhaps their x-rays after their cases, and that x-ray needs to be cleared before they can move to the next level of care or before physical therapy can get them out of bed. So again, this all speaks to kind of that integrated care model we talked about, coordination of care. The middle table speaks to surgeon attestation prior to transfer and the improvement we saw. What is important here is one of the drivers we identified as a driver of delay for on-time starts for our transfers was the surgeon coming to the holding area, signing off on their patient, and attesting, that the H&P or the interval note was read and everything is fine. So we wanted to do a better job of communicating to them that the patient's ready for them to come see the patient. This was important because we have an academic mission here also, and our like I'd like to think that our surgeons are otherwise not in the building or doing something personal, but they have an academic commitment, so they're in conferences, they're in meetings with our fellow and resident staff, so they can't be necessarily present waiting for us to get our job done and get our patient ready in the holding area before they can come and do their thing. So this communication platform also enhanced that. Lastly, you'll see that our average length of stay has also been dropping steadily. Now, I'm not going to say that the implementation of our communication platform was the sole factor in realizing a decreasing length of stay, but when we look at patient readiness for discharge, we need to make sure that they're medically cleared for discharge, that they're surgically cleared and safe for discharge, they're functionally ready for discharge, meaning from a rehab perspective, they're safe and ready to go on to the next level of care, and that their disposition is clear in terms of plan of care after discharge, whether they're going to a nursing home, their own home, an acute rehab facility, what have you. So, those variables need to be accounted for, and the best way to do that is through a communication platform like the one we implemented. Nick, could you go to the next slide? So this was our first crack at a dashboard for analyzing some of our success as well as opportunities, and what was discovered, through this dashboard is a few things. We can identify things like, okay, we're seeing a surge in the number of messages that are happening at certain hours of the day, and perhaps there's not necessarily a clinical need to explain that surge, and quickly, is there some kind of end of shift or change of shift phenomenon happening that's resulting in increased messaging at certain hours, and what's the impact on that? For example, our providers, our PAs, their handoff from day to night is an hour prior to nursing handoff day to night, and if you're going to see a spike in messaging during that kind of golden hour of handoff when you want to minimize distraction, a spike is certainly going to, kind of alert us to perhaps we have an issue here and perhaps we need to focus on something here. We also could talk about, I alluded earlier to service imbalances, and this can help validate that evidence and perhaps can result in us redesigning our services to better distribute our patients amongst our care teams and to be able to deliver more effective and efficient care. So this was very effective in that. Next slide, I believe, is yours, Nick.
So some of the success stories that we saw coming out of this were, once we implemented the technology, things that we didn't even necessarily think of or reasons that we put in the new technology started spinning off of the functionality. So we've started to look at things like, we implemented our acute stroke and seizure protocols for neurology. This really provided that higher escalation of service. So our process for that now is it will require a phone call to our neurologist on call. And for instance, if for some reason, and it's 3 o'clock in the morning, and they miss that call, which most months they're 100% on. But if they were to happen to miss that call, it automatically will re-alert them every single minute until 3 minutes. And at 3 minutes, we actually send the notification to 2 of our other neurologists, and it does the same repeated pattern every minute. And at 6 minutes, it actually alerts the entire department of this message. So that was a good example of something that the neurology department actually came up with, and they're thinking of new ways to leverage the technology to help enhance patient care. We're also starting to think about critical lab results and working on implementing this. So as I'm sure a lot of people on the call have the same process at their hospital, but once a critical lab result is resulted in the system, it requires a lab technician to find the prescriber ordered it, who's on call for that person, and then send them a message that there was a critical result, and it usually requires a callback. What we're trying to do here is really integrate the EHR and the clinical communication platform so that the second that is resulted in the EHR, it automatically sends the entire result to the person on call, and the prescriber has the ability to view the result in the clinical communication platform and acknowledge the result. So that's something we're looking to you know, close the loop on the cycle time, but as well as make it a better experience for our prescribers and our lab in doing this, so getting them the information they need to act quickly on. I talked already about our sepsis response team, but we've actually implemented three different levels of that. So as you saw with the modified early warning system in the 5-minute, we've also instituted the ability that when that PA needs to escalate it to the medical doctor, they have a quick and easy way to do a similar process. And if the patient were to have sepsis, the medical doctor can initiate a communication to an entire care team to bring together about the patient, which notifies about 10 different teams to come together, and it looks at who's on call for each one of those teams. I'm sure a lot of people also have similar use cases and examples of this where, you know, it may be email distribution lists or you know, notifying a bunch of people that are unnecessary at that given time. And we've also started to work on using this with a little bit of telehealth. So we're talking about now being able to connect clinicians at different regional sites and different locations within our organization to have a more of a FaceTime type interaction. And with that, I'll kick it back over to Peter to kind of talk about our lessons learned and takeaways.
Thanks, Nick. So when we look at the 5 Ps, you know, initially, to really realize success with the adoption of this platform, we had to acknowledge the kind of the intimate relationship between our frontline staff, like our PAs, and our physician surgeons or surgeons. Our surgeons really rely on the input of our frontline staff when it comes to processes and kind of problems that arise. So our top-down, bottom-up approach towards this implementation really helped drive success. You know, piloting, it was critical that we did a thorough testing and vetted these communication tools and you know, piloted it on a small scale before unleashing it broadly, because we want to be able to identify any potential flaws that we may not have accounted for during design. You got to prepare for pushback. As Nick alluded to earlier, that there was some pushback when it was declared that the providers needed to provide their own smartphone to use the app. So you have to be able to communicate to that and manage that, and also ensure that it's going to be okay, that it's not going to overwhelm their device or create you know, unexpected problems with their personal device. Also, you need to support them in other ways. You know, look for creative ways to support them. Perhaps you provide them portable charging stations, or in our case, we decided to go not only provide portable charging, we are providing them as a gift a branded wireless charging kind of jacket for their phone that they'll be able to wear on their phone, that will not only keep their phone charged, it'll be for their own personal use as well, but it also has the branded HSS logo, which can really help drive perception when a patient is watching you on your phone. I mean, one of the things we are on the lookout for is how would our patients kind of respond to looking at our clinicians always in their phone. They may perceive that to be a personal issue where in fact it was a clinical issue. In terms of promoting, you know, the balance between standardization and maintaining the art of delivering medical care or surgical care has to be maintained, but there was a lot of variability, as we alluded to, and we really wanted to standardize across services, you know, inpatient, outpatient, as much as we can to realize the efficiency we hope to realize. And, you know, give them guidance. Give them guidance. An example of that might be messaging etiquette. You know, while it's a texting feature, you don't necessarily want to use some of people's texting habits as a way to communicate in your communications platform. You know, the thank yous, you know, the reply alls, things of that nature can create, you know, kind of unnecessary communication and distraction, and we wanted to be aware of that and try to avoid it. And lastly, the last learning or takeaway from this is that when we set about making this change, what we learned was we had to find the right person who's going to ask the right question for the right problem in the right way to affect the change. And, you know, when you look for change agents in your organization, you realize that change agent can be from just about any department. It could be an IT person, it can be an informaticist person, it can certainly be an operational person, or it could very well be a clinical person. The key for leadership at a given organization is to find that person, because they're out there and they can certainly help you realize the change you seek. With that, I'll turn that back to Nick.
Just to wrap up the presentation, here's kind of what the next steps are for HSS and what we're working on. So I mentioned the Critical Lab Value Project, also working to embed the communication platform within the EHR, so it's more seamless for our clinicians and not having to work into two different screens. Virtual consults, I also talked about connecting providers at different regional sites to be able to further enhance patient care, and also the ability to mine data and look for trends in what's going on and get a pulse over the organization, and bringing that really to the different department leaders and be able to have a pulse on their own teams rather than having to always go through, you know, the typical organizational process where everything has to go through who owns the data, giving them dashboards to easily view and access this when they need to. And then we're also looking at increasing mobility for nursing. So this year we're working on rolling out a mobile device for nursing that incorporates both the clinical communication app, also the EHR, and other like call bell systems, those types of things, so it doesn't tie them to a workstation or the unit desk. And that is all we had. So with this, I'll probably kick it back over to Anthony.
All right, very good, Nick and Peter. Thank you so much for that presentation. All right, we have time now for our Q&A, so to those of you in the audience, please go ahead, type in your questions in the Q&A box and leave the default set to all panelists, and we will get those in front of Nick and Peter. Nick, regarding a hospital for special surgery, what's your percentage of employed physicians versus independents that are credentialed to practice?
So mostly on the surgical side, we have about, I'd say 70% of our orthopedic surgeons are private physicians, and the other 30% being contracted. But as you go through their practices, it's the same look and feel. There's not really, you can't really tell the difference. A lot of them even share the same space. So on our more on the hospital side, most of them are employed or contracted, I think separately, other than maybe our anesthesia group. But I think one of the things about our culture here is we have an academic medical center that our providers really almost all of them only work at HSS and operate at HSS.
Did you find there was a difference in the approach you had to take for rolling out this or any other technology in terms of approaching the independents versus approaching the contracted physicians?
No, I think the culture we have here, each service line has kind of their own business meetings, and a lot of things that we've rolled out with them in the past, we've piloted with either a service line or an individual surgeon that they then bring to their business meeting, and then rolls up to a larger governance structure. But I think a lot of what we do, it's more of a shared decision-making model that we have, and a very good relationship between the hospital and even our private physicians.
The only thing I would add to that is that, yes, the culture here at HSS is to really, not be able to discern the difference between a private physician and a contracted one. Is that to the lay clinician, for example, there's no way for them to tell, and that really speaks to kind of how they're treated, how the consistency in which they're treated, depending on whether they're private or hospital based.
All right, very good. Peter, let's go with you on this one from the audience. In your selection process, how many vendors did you involve, and what was the makeup of your selection team?
That's a great question, but I actually think it's a better question for Nick.
All right, Nick.
Yeah, we looked at about 4 different vendors. Then we brought 3 of them in, did a vendor analysis across them. I think the key differentiator in the vendor that we used was that they were able to bring the answering service, the outpatient communication, and the inpatient communication into the same technology. That was the big differentiator that we saw. Part of in our team that we used, we had about 20 different people. So Peter leading the PA department, our VP of nursing, we had PT, case management, really all specialties across the organization.
Very good. And did you do, you probably covered this, but what's your best advice in terms of rolling things out and then piloting and then extending out? Is that the approach you take?
Yeah, I would, and Peter, feel free to jump in, but I think the approach we took with getting the buy-in from the physician offices and being able to start there really helped drive the adoption at the hospital. I think in that setup, we were also able to, you know, in a lot of these answering services, we're able to, with technology, experience some savings. So my advice to other organizations, if you start there, realize savings, you can then apply them to the hospital implementation.
Very
good.
The
other thing I would say, and the approach for going through the surgeon offices first was getting credibility with them. If we had done it the other way around, we probably could have predicted a little bit more resistance and concern to change because they may not have felt it as impactfully as when we went through the surgeon offices first.
Yeah, I would definitely echo that. That was, you know, prior to working at HSS, I worked in consulting, and one of the big things that you would hear in working with physicians is that, oh, this is a hospital initiative, or the hospital is making us do this. I think it was really a different kind of experience here where the physicians were coming to us in the hospital saying, like, this is great, we need to get this moving.
Gentlemen, where are we with texting? What are you allowed to do versus what you're not allowed to do? I believe this is currently sort of being debated by the government, and last I saw you were not allowed to text orders. But you tell me, where are we?
Well, I would say that here at HSS, we don't allow texting of any orders. All orders have to be implemented into our EHR. You know, the texting that we use in Perfect Serve is, you know, in a HIPAA compliant standardized platform. It's not texting, you know, between you and I, for example. But we don't allow orders currently.
And I would also just add on with the that's something we wanted to state out in that clinical communications policy, was that the EHR is the source of truth for documenting patient care and ordering. It was not to be used, the clinical communication platform was not to be used in the same way.
And is there any way for a health system to know if clinical type texting is going on outside of a platform where it should be going on?
I apologize, Anthony. I checked out. I didn't hear that entire question.
Oh, go ahead. I'll say it again. Is there any way for a health system to know if clinical type texting is going on outside of the platform where it should be going on?
Yeah, to my knowledge, I don't think there is. I mean, you know, and that was one of the things why we needed to adopt this, is that the cultures that evolved on their own as a response to the deficiencies we had with our previous system created these kind of outliers where they were either texting or emailing or God knows what to communicate, and we knew that that was not safe or protected. So, but to answer your question, I don't think we can.
Right, right. No. So it's just, you want to make it easy for them to do the right thing. Does that make sense, Nick?
Exactly. Exactly.
Yeah, because, I mean, with anything that you implement at an organization, people find if it doesn't work well or the process isn't going well, you know, the teams, the individuals are going to find workarounds to make their lives easier. And so I think it's our responsibility to make it as easy as possible to do things in the right way and in a safe way for them.
Last question, gentlemen. Do you have any knowledge of whether or not this rollout has implemented clinician job satisfaction? you know, you could imagine it either way. Either it makes their job easier, or it, you know, you mentioned the one person with the pager or the phone getting stuck with all the work, and it's hot potato with that item. So you could see the two people, you know, in our little scenario, the two people that are able to hide, they loved the old world because they didn't have the phone or the pager, but now it's all distributed. So you could see it going up or down in terms of job satisfaction, depending on where you're coming from. What are your thoughts?
I think that's funny you said that. I think overall, huge satisfaction. You know, they call out unintended consequences as a result of this implementation? Absolutely, and what was great about the vendor we chose is that, you know, we worked very closely with them to overcome some of the initial kind of stumbling blocks we encountered when we went live. But overall, very positive. In terms of your specific example, they can run, but they can't hide. You know, even in the paging world, you know, their colleagues would call them out. You know, those people who perhaps could hide, for example, they were rooted out, you know, by their own very quickly, you know, because everybody wanted to be treated equitably.
Yeah.
And I would say that,
go ahead.
And the biggest thing too, I think that we've seen, you know, in feedback as a measuring factor of success is we're getting a lot of departments now that will come to us and, you know, recommend improvement projects or further enhancing the platform on their own. And it's almost become this culture of transformation or a culture of change rather than, you know, one specific group doing everything.
Excellent. Well, it sounds like you gentlemen are doing great work over there and enjoying yourselves doing it, which is wonderful. So we're about out of time. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. Regarding continuing education, attending our events gets you 1 CEU towards the CHIME CHCIO certification program. So please let CHIME know you were here, and if you've asked us to do so, we will. If you need a CEU for another program, a certification, you can use the final slide in this deck. You'll get an email when a recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule. So with that, I want to thank Nick Wirth and Peter Grimaldi very much. Really enjoyed the event today, and I want to thank you, our audience, for joining these events. So with that, everybody have a wonderful day. Thank you.
Thank you.